thank you all for being here tonight. Thank you for your interest and your really willingness and enthusiasm to learn more about nitric oxide. So over the next hour, I'm going to introduce some concepts about really strategies to enhance your practice and get healthier patients by integrating nitric oxide. And so by way of background, I've been in nitric oxide for more than 20 years. My research program has really been focused on answering 4 fundamental questions. Number one, how does the human body produce nitric oxide? What goes wrong in these people that can't make it? What are the clinical consequences? And then perhaps most importantly, how do you fix or restore nitric oxide production in your patients? And over the course of those 20 years, I've had a number of discoveries, many issued US international patents, published many peer-reviewed papers on nitric oxide. And I've given over 200 lectures worldwide. And over the course of that 20 years, when you make discoveries, there's what's called conflicts of interest, and I'm obligated to share those with you. Here's a list of the companies that I've either started or have licensed my technology for product development. So what I thought we would do was really give you a working conversational knowledge of how nitric oxide signals in the human body, show you real evidence that what goes wrong in people that can't make nitric oxide, what leads to endothelial function, how this contributes to chronic disease, and then reveal the effects of dietary nitrite and nitrate on human health. And then finally, we'll bring all this back together and I'll instruct on how to improve nitric oxide in your patients based on real science. So over the past probably 30 years, there have been a number, dozens, if not hundreds of nitric oxide products that hit the market. Started with arginine and citrulline, most recently beetroot, green leafy vegetables, greens products, nitrate. And so what I hope to do is kind of give you the history of this, because these products don't just show up on the shelves or on the internet. There's real science behind this and a rationale and justification for these types of products. So my objective is to inform you so that you know, and my goal here is not to sell you products, but really to inform you and educate you so that you and your patients know how to carefully choose products that are based on real science and not deceptive or creative marketing. And this goes back to the fundamental principle that's been my guiding light for the past 20 years, is to see what everyone else has seen, but to think what no one else has thought. And that's very difficult, especially in nitric oxide, because I believe there are over 175,000 papers published in the scientific literature. So there's a lot of noise out there. And so to be able to think differently is what separates many people from others and many products from others. But beyond nitric oxide, what I've learned in 20 years of academic medicine and research is that chronic disease is caused by 2 things and 2 things only. It doesn't matter if it's cancer, heart disease, kidney disease, lung disease. It's 2 things. The body's exposed to something that it doesn't need, or it's missing something that it needs. And mechanistically, the end result of this is disruption of nitric oxide production, decreased circulation, increased inflammation, oxidative stress, and immune dysfunction. And those are the hallmarks of every single human chronic disease. And if you distill it down to that basic simplified theory, then to treat chronic disease, you just have to do 2 things. Get rid of toxins, give the body what it needs, enhance nitric oxide production, and the human body heals itself. And we can do this, we can look inside through non-invasive imaging. One of these SPECT scans, and this is data from Daniel Amen's clinic, but basically it gives you an inside look at how well the organ, in this particular case, the brain, is perfused. And you can see these images here on the left. You can see the nice contour of the brain. This is reflective of sufficient perfusion. So this brain here, a healthy brain, is getting sufficient blood flow to all regions of the brain. And to the contrary, if you look on the right, this is an unhealthy brain, a patient with post-concussion disorder who developed addictive disorder, substance abuse. And you can see these holes in the brain here are reflective of decreased blood flow to certain regions of the brain. So without blood flow, without oxygen, without nutrients, these cells of particular parts of the brain can't function. And that's the basis for any disease. In this case, any neurological disease, but it's not isolated to the brain. Same thing happens in the heart. If you have a disruption of the blood flow to the coronary arteries, have an MI, heart attack, a lot of people die. In fact, it's the #1 killer of men and women worldwide. So the key is, and this is reflected in reperfusion therapy, is if you have a block here, in this particular case, the left circumflex, you go in through angiography and you dissolve the clot or aspirate the clot, you restore blood flow, and this patient actually recovered very nicely. But if you don't restore the blood flow, the heart dies, the patient dies. So the point here is you have to have sufficient blood flow to treat acute disease, such as an MI, or to treat chronic disease, such as slow progressive vascular dementia or any other end organ disease. So this is going to go for 50 minutes, but if you wanted to stop off right now, if you had something else to do, this is the most important slide. Nitric oxide deficiency causes chronic disease, increases your risk and sickness and mortality from viral infections, including coronavirus. And I'll touch on that later. So the most important thing you can do is enhance your body's ability to make nitric oxide. That's the take-home message. Now, the detail of that is how do you do it? How best to do this? Everybody's different. And so we have to look at personalized medicine and get to the root cause of what's causing nitric oxide deficiency. So again, this is kind of a rehash here, but every single chronic disease is characterized by decreased blood flow. But in the scientific literature, it's known that if you can restore blood flow and perfusion to every organ, tissue, and cell in the body, you can correct most, if not all, chronic diseases because the human body heals itself. That's just the way we're made. So the fundamental question is, how do you restore blood flow and perfusion to specific organs and tissues and cells throughout the body? And that's where this molecule, nitric oxide, is absolutely essential. You cannot do it without nitric oxide. And this was so important that a Nobel Prize was awarded in 1998, and Val Fuster was famously quoted as saying that the discovery of nitric oxide and its function is one of the most important in the history of cardiovascular medicine. And at the time of its discovery, we thought, or we knew, that it was important as a vasodilator, meaning that it dilated blood vessels, increased blood flow and oxygen delivery to downstream tissue. In the 30+ years since that discovery, we've learned that it's a signaling molecule. So the basis for its importance is how it signals. And this paper here, published by Jonathan Stammer in 2015, really illustrated the importance of nitric oxide as a signaling molecule, independent of its vasodilatory properties. So most of you are familiar with the cardiorespiratory cycle, where we breathe in oxygen, it binds to hemoglobin, it's transported throughout the body. And when it goes to this arteriovenous transit, hemoglobin undergoes an allosteric transition, a change in structure. It releases oxygen, picks up CO2, and the venous circulation excretes it through the lungs. But this paper here demonstrated that you need nitric oxide bound to a single cysteine residue on the beta chain of hemoglobin in order for oxygen to come off. If you don't have nitric oxide bound to hemoglobin, oxygen will not come off. And over the past 2 years, this has become very apparent in COVID patients because the problem in coronavirus infection is the loss of oxygen saturation. You give them 100% oxygen, increase the flow rate, but many times you don't increase the oxygen saturation. Why is that? Because they're missing nitric oxide. If you restore nitric oxide, you improve oxygenation, and more importantly, you improve delivery of that oxygen to every cell, tissue, and organ in the body. So your body cannot and will not heal or improve oxygenation without nitric oxide. And I'll show you how we're developing nitric oxide-based therapeutics for COVID that's showing that nitric oxide is what's necessary and sufficient for improving coronavirus infection, sickness, and death. And it's more than just the vasodilating the cardiovascular system. It's how our own immune system kills off invading pathogens like viruses and bacteria. So when we become infected, whether a bacteria or a virus, our immune system mobilizes for neutrophils and macrophages and monocytes, generate a lot of nitric oxide, shuts down bacterial respiration, prevents viral replication. And so if you're healthy and have sufficient nitric oxide, you get exposed to a pathogen, but our body quickly mobilizes the resources, shuts down the infection, and you don't get sick. However, if you're deficient in nitric oxide, you can't mobilize an immune response, you get exposed, you get sick, you go to the hospital, and you die. That's really the basis of nitric oxide and immune function. But it controls, it's the non-adrenergic, non-cholinergic mediator in the periphery, controls gut motility, It's the main molecule that tells our own stem cells to mobilize and differentiate. Neurotransmitter in the central nervous system controls cell cycle, important consideration in cancer, dilates respiratory, the smooth muscle of the respiratory tract, and it's the main molecule responsible for sexual function in both men and women. In fact, if you can't make nitric oxide, the first sign and symptom of sexual dysfunction. And in 1998, a Nobel Prize was awarded to Bob Furchtgott, Lou Ignarro, and Fred Murad for the discoveries of nitric oxide as a signaling molecule in the cardiovascular system. And in 1977, Dr. Murad made a very important discovery that revealed that drugs like nitroglycerin or organic nitrates that were used for the treatment of acute angina for 150 years prior to this, they worked because these drugs were metabolized into nitric oxide. They dilated the arteries and restored blood flow to the ischemic myocardium. And then in 1980, Bob Furchtgott discovered that our endothelial cells makes the substance that causes blood vessels to relax. In his 1980 Nature paper, he called this endothelium-derived relaxing factor, or EDRF. A very important, probably one of the most important discoveries in vascular biology. Then the race was on to identify EDRF. And in 1987, Lou Ignarro and Salvador Mucata discovered that EDRF is nitric oxide. And so whether you enhance endogenous nitric oxide production or give an exogenous NO donor, the result is the same. You improve blood flow, improve oxygenation, improve nutrient delivery to every cell in the body. That's the basis for the Nobel Prize and how important nitric oxide is in science and medicine. And Bob Furchtgott passed away several years ago, but Lou Ignarro has written the foreword to several of my textbooks. And it was Dr. Murad who recruited me to join the faculty at UT Medical School in Houston back in 2005. So many of the discoveries we made were with Dr. Murad as my department chair and really in the drug discovery program of how do we develop safe and effective nitric oxide-based therapeutics. So what are the consequences of nitric oxide production for many healthcare practitioners? You need to recognize these symptoms that hopefully prior to today you didn't recognize, maybe a nitric oxide problem. Obvious is hypertension. If you lose the molecule that maintains normal blood pressure, you develop high blood pressure. Erectile dysfunction, vascular dementia, diabetes. We'll delve into diabetes and show you that diabetes is really a symptom of nitric oxide insufficiency. Peripheral artery disease, small vessel disease, atherosclerosis, blood clotting disorders, extremely important now in COVID and the spike protein, acute respiratory distress syndrome, heart failure, acute kidney injury, and immune dysfunction. These should all be very familiar with those of you on the webinar tonight because these are the risk factors for COVID, not just COVID, any respiratory infection. And if you have any of these symptoms, your risk of getting COVID, getting sick from COVID, and dying from COVID can go up tenfold. So this explains the etiology of not just the COVID epidemic or pandemic, but seasonal flu, people who are prone to bacterial infections. And if we get to the basis of this, again, I like to go back to the basics, that a man is as old as his arteries. This quote here is centuries old, but it still holds true. And so it's known that the older you get, you start to get stiff blood vessels, you start to get some plaque, lipid deposition underneath the lining of the blood vessel. And over time, this plaque becomes unstable. This is hallmarks of inflammation, oxidative stress, and immune dysfunction. And this plaque then ruptures, and you have a heart attack or stroke. #1 killer of men and women worldwide. So we began to interrogate what happens, where does nitric oxide play a role in this whole atherogenic process? And now we know that if your body can make nitric oxide, if you have good endothelial function, then you don't get intermediate thickness, you don't get the inflammation, oxidative stress, and immune dysfunction, you do not get plaque deposition, and you do not have a heart attack or stroke. However, if you lose the ability to make nitric oxide, that sets the stage for inflammation, oxidative stress, and immune dysfunction that causes cardiovascular disease, heart attack, and stroke. And in fact, these functional loss of nitric oxide production precedes these structural changes by many years, sometimes decades. So the most important thing you can do, or the most important consideration, is to make sure that your blood vessels can make sufficient nitric oxide, because now we know clinically that if you have good endothelial function, you will not get atherosclerosis, you will not get cardiovascular disease, and you will not be a statistic of the #1 killer of men and women worldwide. So let's go back to the problem, address the fundamental problem. I like to address really the elephant in the room, and that's cardiovascular disease. It's the #1 killer of men and women worldwide. Despite billions of dollars in research, these numbers have not gotten better. In fact, one could argue they've gotten worse. To me, this is unacceptable because we know unequivocally what causes cardiovascular disease, we know how to diagnose it, and we know how to treat it. So the problem is not the science, the problem is in communication, education, and awareness. And that's why these webinars are so important to inform people, because now there's no excuses. So cardiovascular disease accounts for 1 in every 4 deaths. Over 500,000 people die of heart disease every year. This should be the headlines, not the deaths from COVID. Every 42 seconds, someone has a heart attack, and every minute, someone dies from heart attack or heart disease-related event. And let's put this in perspective. If there were 4 jumbo jets crashing and killing everybody on board every hour of every day, this would be the headlines, right? That's the number of people that die from cardiovascular disease. So let's go back and look at the science. What causes cardiovascular disease? Cholesterol? No way. This is one of the greatest myths ever perpetuated in the scientific literature. Cholesterol does not cause cardiovascular disease. Of course, smoking does, poor diet does, poor oral hygiene, oral infections, sedentary lifestyle, inflammation, and even prescription drug therapy contributes to cardiovascular disease. So if you take all these and look at what's the common denominator in all these, whether you smoke, poor diet, oral hygiene, it's a disruption in the production of nitric oxide. Let's move to diabetes. It's a growing pandemic worldwide. Almost a third, or 32 million Americans have diabetes, about 10% of the population. Pre-diabetes, even worse, about a third of the population. 24 million Americans age 65 and older have pre-diabetes. The burden on the healthcare system is astronomical, $327 billion. It's growing. These data from 3 years ago, it gets worse every year. And scientifically, we've known that once you get diabetes, it leads to a decrease in nitric oxide production, a number of well-defined mechanisms. And we know that people don't die from diabetes typically, unless you go into a ketogenic shock or acidosis. You die from the vascular complications of diabetes, heart attack or stroke. So when you get diabetes, this decreases nitric oxide production, you increase cardiovascular disease severity. However, this data by Paul Wang in 1995, where he knocked out the nitric oxide synthase gene in mice, their first phenotype was insulin-resistant type 2 diabetes. So a mouse that can't make nitric oxide develops diabetes. So this told me that if you have insufficient nitric oxide production, you get diabetes. Once you get diabetes, it further suppresses nitric oxide production. So no wonder diabetes is poorly managed, because metformin, glucophage, all these anti-diabetic medications aren't addressing nitric oxide. That explains the poor management of diabetes. And then this study that came out more than 10 years ago by my colleagues at the Karolinska Institute took these eNOS deficient mice who had diabetes, and they just gave them inorganic nitrate, potassium nitrate in the drinking water. And you can see here, so these are mice who cannot make nitric oxide. Give them nitrate in the drinking water. They don't gain as much weight, even though they eat the same amount of food. Significant reduction in triglycerides, about a 50% reduction in visceral fat deposition. Blood glucose curve improves. Fasting glucose levels improved, about a 50 to 60% reduction in hemoglobin A1C. And the ratio of proinsulin to insulin decreases by about 40%. So this demonstrates that if you have diabetes, or if you can't make nitric oxide, you have diabetes, you can completely correct this through dietary intervention. And that is only part of the story, because we know that diabetes are to reduce the glycemic index, to eat not to eat high processed carbohydrates, but that's just part of the story. You have to include more nitrate in your diet to overcome the metabolic defects caused by insufficient nitric oxide production. And then the blood pressure. Nitrate reduces blood pressure. So this corrects all the metabolic phenotypes of diabetes in an animal model that can't make nitric oxide. You completely overcome that genetic deficiency. And I'll give you another example in humans towards the end of this talk. So we were aware of that data, and so we began to interrogate mechanistically what's going on. How is this happening? And so we looked at the insulin signaling pathway and where insulin binds to the insulin receptor, and then that initiates a series of protein kinases, the PI3 AKT kinase, and then AMP kinase, which is the target of metformin. And all of these, both of these converge on eNOS, the enzyme that makes nitric oxide. But we know in diabetes, this enzyme is there, but it's not functional. So we did know what happens here. And then the terminal step in this is GLUT4 translocation. It goes from the cytosol to the membrane, it binds glucose, increases glucose uptake, and improves fasting glucose levels. But in diabetes, you can't make nitric oxide. So what happens? What happens to GLUT4? When we published this in 2014, and this is the control up top, but these are green fluorescent protein tied to GLUT4. So we can visualize GLUT4 translocation in real time. So in the control here, you can see nothing happens over time. If we just give nitrite to these cells, you can see here that the periphery, the membrane of these cells start to light up. So you can see this cell here. We give nitrite, GLUT4 goes to the membrane and improves glucose uptake. And mechanistically, we know that GLUT4 has two cysteine residues that are conserved throughout evolution. And when these cysteine residues, similar to the cysteine on hemoglobin, it's post-translationally modified by nitric oxide or nitrite, then that's necessary and sufficient for GLUT4 translocation to improve glucose uptake and improve the diabetes phenotype. So unless you modify these cysteine residues with nitric oxide, you don't get glucose uptake and you don't improve the management of diabetes. Nitric oxide is absolutely essential in the management of diabetes and glucose uptake. And again, we published that in 2014. And to the contrary, if you have healthy people that have good endothelial function, when you begin to exercise, your body generates a lot of nitric oxide. In fact, your ability to perform and your ability to increase to meet the increased metabolic demand on the heart when you begin to exercise is dependent upon your ability to generate nitric oxide. So plasma nitrite predicts exercise capacity. This is a study published in young, healthy individuals. If you take older patients with endothelial dysfunction, you put them on an exercise treadmill, their body cannot make nitric oxide. They failed on exercise stress tests. They failed to increase plasma nitrite in response to exercise. And this is diagnostic for coronary artery disease. So your ability to generate nitric oxide is absolutely essential in your ability to exercise and your risk for cardiovascular disease. So with that being true, based on the published science literature, the fundamental question is how to control and regulate nitric oxide production. Because once we understand this and we understand how to fix it, we can treat, prevent, and cure really any chronic disease based on how nitric oxide works. And there's two pathways to make nitric oxide. The first pathway to be discovered was through an enzyme called nitric oxide synthase. This takes arginine, converts it to nitric oxide. The other is through a dietary intervention where certain foods enriched in nitrate can be metabolized into nitrite, nitric oxide. Stoichiometrically, we know that about 50% of nitric oxide comes from both pathways. One can compensate for the other, but if you have endothelial dysfunction, if you don't get enough nitrate from your diet, or if you're using mouthwash, antacids, and you shut down both of these, then you become completely deficient of nitric oxide, and you're at an increased risk and a slippery slope to cardiovascular disease. And this is the pathway to make nitric oxide from L-Arginine. I published this in 2011. And people thought for years, well, I'll just give arginine and get nitric oxide. Well, that couldn't be farther from the truth. Because people failed to recognize what's in this blue box here. This is one of the most complicated and complex reactions in the human body. So this enzyme, nitric oxide synthase, converts this guanidino nitrogen here in a 5-electron multi-step oxidation reaction to generate nitric oxide. For this reaction to occur, you need sufficient tetrahydrobiopterin you need these reduced cofactors, you need oxygen, you need glutathione. And if any of these cofactors become limiting, this enzyme becomes uncoupled, there's a disruption in the flow of electrons, and you generate superoxide and nitric oxide. Interestingly, if you give high dose L-Arginine, you push this reaction to the right and generate superoxide. So giving arginine to a patient with endothelial dysfunction is like putting gas in a car with a blown up engine. You're not out of fuel, you're not out of gas, you're not out of arginine. The engine to convert it is broken. So in fact, you can do more harm than good. And then we've discovered that once nitric oxide is produced, it can bind to glutathione and form S-nitrosyl glutathione. It oxidizes to nitrite and nitrate, and then we can recycle it. So if you're using arginine or citrulline-based products, save your money. It's not necessary. These are semi-essential amino acids. Your body makes sufficient of these amino acids to fuel this reaction. And this is normally how it works. So if you can appreciate, this would be the lumen of a blood vessel. This is the single layer of endothelial cells. And this is the smooth muscle that surrounds all blood vessels throughout the body. So the best example is when we begin to exercise, this causes shear stress in the lumen of the blood vessel. That tells nitric oxide synthase enzyme, I need nitric oxide, and it turns this enzyme on, converts arginine to nitric oxide, provided this enzyme is functional. And then nitric oxide is a gas. It diffuses in 3 dimensions. So part of it diffuses in the lumen of the blood vessel where it interacts with platelets, monocytes, and neutrophils. Part of it diffuses into this underlying smooth muscle where it activates an enzyme called guanylyl cyclase. That's the enzyme that Dr. Murad had discovered, becomes activated by nitric oxide. And then guanylyl cyclase converts GTP into cyclic GMP. And cyclic GMP is the second messenger that's responsible for the calcium-dependent relaxation. And I'm sure most of you, if not all of you, are familiar with the drugs like Viagra, Cialis, and Levitra. These are what's called phosphorylase inhibitors. They prevent the breakdown of cyclic GMP. And we know now with these drugs on the market for many, many years, only 50% of the men that are prescribed Viagra respond with better erections. Why is that? It's because their body doesn't make any nitric oxide here to lead to any appreciable accumulation of cyclic GMP. So erectile dysfunction is a symptom of insufficient nitric oxide production, not a symptom of overactive phosphodiesterase activity. And now we know that you can turn non-responders to PD-5 inhibition therapy into responders by giving them a little bit of bioactive nitric oxide. The problem is the function of this enzyme decreases with age. In fact, we lose about 10 to 12% of our endothelial function with each decade. By the time we're 40 years old, we only have about 50% of the nitric oxide we had when we were younger. This, not coincidentally, is the age that people start to feel the effects of aging. 50% of the men over the age of 40 self-report some degree of erectile dysfunction. 50% of the men don't respond. They start to lose cognitive dysfunction. It's not just men, it's women too. And so the older you get, the less nitric oxide you make through the endothelial nitric oxide synthase pathway. So our thought was, if we can prevent this age-related decline in nitric oxide production, can you prevent age-related disease? And in an hour, I don't have time to go through all the studies, but the answer is yes. So understanding that our endothelial function becomes worse with age, can we start to use nutrition, food, or supplements to provide nitric oxide support to compensate for the loss of endothelial nitric oxide production? And again, we go back to the basics. The air we breathe is 78% nitrogen. This nitrogen is fixed primarily through lightning fixation or by nitrogen fixing bacteria that take ammonia or nitrate. It's added as fertilizers or organic matter. Then any vegetable that we eat that's grown in the soil, we're getting a source of these nitrogen oxides. Or any animals that we eat that eats the grass, we're getting a source of these nitrogen oxides. And now, so this is what's called a nitrification process. The human body is a denitrifying process. So when we eat spinach, green leafy vegetables, or get a source of nitrate, this nitrate is taken up in the gut, the proximal gut, the duodenum. And then that nitrate is concentrated in our salivary glands. So then so about 90 minutes after we consume a nitrate-rich product, or food, it's concentrated in our salivary glands. Then when we salivate, there are nitrate-reducing bacteria that live in the dorsal part of the tongue, the crypts of the tongue, and they convert nitrate to nitrite. So the 2-electron reduction. Humans do not have this enzyme, so we're 100% dependent upon these bacteria. And then when we swallow our own saliva, the pKa of nitrite is 3.4, which means that at pH of below 3.4, 50% of the nitrite becomes protonated, and then we generate nitric oxide gas in the lumen of the stomach. And this nitric oxide that's produced in the stomach from swallowing our own saliva kills H. pylori, kills E. coli, kills salmonella, kills foodborne pathogens, prevents gastric ulcerations from chronic NSAID use, enhances gastric mucosal blood flow to increase absorption of B vitamins, iodine, zinc, trace minerals. So this is critically important and a fundamental physiological process that's required for normal, healthy metabolism. However, if you use mouthwash, you kill the bacteria, you disrupt this. If you're using antacids, you decrease stomach acid production, you prevent nitric oxide production, you become nitric oxide deficient. And I'll show you the data on that shortly. So going back to kind of the fundamentals of what we do, in the preclinical studies and even now in human clinical studies, we know that nitrate is sufficient for lowering blood pressure and improving exercise capacity. But how much do you need? You need at least 300 to 400 milligrams to see any changes in blood pressure or improvement in exercise capacity. We looked at food consumption tables, nitrate content of the standard American diet, which we call the SAD diet, and revealed that we're only getting about 150 milligrams of nitrate per day. And that's over 2 to 3 meals. So just as most Americans are deficient in magnesium, selenium, chromium, iodine, important nutrients, we're a nitrate deficient population. We don't get enough nitrate from our diet. And then we compared certain dietary patterns. The Japanese diet, which is known to be health promoting, cardioprotective, cancer protective, and even the DASH diet, the dietary approaches to stop hypertension, we published, I think, in 2005. The reason it lowers blood pressure is because the nitrate content of this particular dietary pattern is above this threshold, this 300 to 400 milligram threshold to lower blood pressure. These other dietary patterns, the US diet, European diet, Polish diet, this tells us that there's a clear association between dietary patterns and nitrate intake and normal blood pressure levels. So then we took it one step further. We were so bold to think if we could change dietary guidelines, how much broccoli or celery or beets or spinach would you need to eat to get enough nitrate to lower your blood pressure? So in collaboration with Texas A&M University, we went to 5 different cities across the US and took vegetables off the shelf, brought them back to the lab, and we just measured their nitrate and nitrite concentrations. We did this in conventionally grown vegetables, and we did this in organically grown vegetables. And this is the data. This is one table from this paper we published in 2015. A lot of numbers here. So we took broccoli, cabbage, celery, lettuce, spinach from Chicago, Dallas, Los Angeles, New York, and Raleigh, all across the US. And the point I want to make here is let's just take celery, for example. If you lived in Dallas and you went to the local grocer and you bought celery off the shelf, you could eat 6 ton stalks of celery, and that would translate into about 300 milligrams of nitrate, and that's sufficient to normalize your blood pressure. If you lived in New York and you went to that same retail grocer and bought celery off the shelf, you would have to eat 30, 40, 50 stalks of celery to get enough nitrate to lower your blood pressure. So this told us that there's no way you can make dietary recommendations because it depends on where you live. Now we know that this is based on farming practices. Not only that, the amount of lightning in these specific regions to enrich the soil in nitrogen-based fertilizer. And it's the same across vegetable categories. Interestingly, if we compared organic to conventionally grown, organic vegetables have on average about 10 times less nitrate than conventionally grown vegetables. So the point here is you cannot eat enough organic vegetables to get enough nitrate to normalize your blood pressure. And the reason for this is to have an organic label, you can't add nitrogen-based fertilizers to the soil. So there's restrictions. So organic is good because you're not getting exposed to herbicides or pesticides, but it's not good because you're not getting enough nitrate. And nitrate is what's required for the assimilation of other nutrients, like selenium, certain vitamins. So if your vegetables are deficient in nitrate, they're deficient in other trace minerals and nutrients. The other problem in this whole pathway is nitrate is inert in humans. As I mentioned, we need bacteria in the oral cavity, in the GI tract, to reduce nitrate to nitrite. There are 200 million Americans that use mouthwash every day. 200 million Americans use antacids, and there are over 200 million prescriptions written for antibiotics every year. So everything we do on a daily basis as Americans are killing the bacteria, especially in this time of COVID. We're using antibacterial, antiseptic hand lotions. Everything we do, this antiseptic environment we live in, is actually leading to more disease because we're killing the microbiome. This paper here was the first to demonstrate that if you use mouthwash, you see an increase in blood pressure. And these are normotensive patients. The only thing they did was give them mouthwash for 7 days. And after 7 days, their blood pressure increased and their plasma levels of nitrite decreased. And remember, plasma levels of nitrite predicts exercise capacity, is a biomarker for endogenous nitric oxide production. So we began to interrogate this because it was interesting to us, because from the microbiome perspective, the human genome is only 23,000 gene products. The bacteria that are in and on our body provide 3 million gene products. And these bacteria are there to do things that we as humans can't do. So we started a study at the Texas Medical Center, where we took patients around the Texas Medical Center, and we did tongue scrapings, and we wanted to see what was growing in their mouth, and did these bacteria have any relation to their blood pressure. And so we were hoping to capture and culture some nitrate-reducing bacteria and see, did this have any effect on their blood pressure? And these are the data we published in 2014, that people with normal blood pressure had a higher diversity of the microbiome that was growing in their mouth. And many of these bacteria were known what's called nitrate reducers. If you had high blood pressure, then there was less diversity and less of these nitrate reducing bacteria. So this study here showed a clear association, not causation, association between the presence of certain oral bacteria and normal blood pressure. We took this a step further. We got another IRB, and we did another study and just tried to find, okay, if we take normal, healthy individuals and we did tongue scrapings, we did blood pressure measurements, and then we gave them a mouthwash for 7 days, twice a day for 7 days, what happens to the bacteria, what happens to their blood pressure. And this is a figure from our paper we published a couple of years ago. And this here showed a single patient, a 21-year-old dental student, 7 days after starting mouthwash, his blood pressure went up 26 millimeters of mercury. A healthy 21-year-old high-trained athlete made him clinically hypertensive in 7 days just by giving him mouthwash. Interestingly, in these tongue scrapings, we found bacteria that disappeared when his blood pressure went up. And 4 days after stopping the mouthwash, his blood pressure normalized, and we picked up the bacteria that reappeared at the time his blood pressure normalized. We did a full metagenomic analysis of these bacteria. They were expressing these nitric oxide producing enzymes, and found that the presence and number of these 4 bacteria predicted and correlated with systolic blood pressure. So this explains a lot of things in cardiovascular medicine. It explains resistant hypertension, because people who are put on standard blood pressure lowering medications, their blood pressure doesn't normalize because it's the wrong target. Hypertension in many cases isn't a renin-angiotensin problem. It's not a calcium imbalance. It's not a fluid imbalance. So ACE inhibitors, ARB, calcium channel antagonists, and diuretics won't affect these patients. Hypertension is a symptom of oral dysbiosis. Now, how do we correct that? So everybody here has a different oral microbiome. Probably everybody has a different diet, certainly different genetics, different lifestyle. So how do we create a technology that works the same in everybody? And again, we go back to the basics, that the earliest signs of cardiovascular disease is inflammation, oxidative stress, and immune dysfunction. The earliest signs are when monocytes and T cells and neutrophils start to stick to the lining of the blood vessel. They migrate through. This is the inflammation, oxidative stress. They're modified by our immune system, modified LDL, macrophages, foam cells, immune dysfunction. But it's known that if you can prevent this early inflammatory response, you can prevent the progression of cardiovascular disease. And this is real-time intravital microscopy from a paper we published in 2009. And this is feeding an atherogenic diet. So this is a single blood vessel here. You can see that the blood vessel is like Velcro. These monocytes and neutrophils stick. There's a little bit of blood flow getting through here, but this is a heightened state of inflammation, oxidative stress, and immune dysfunction. If we take that same atherogenic diet, but we give nitric oxide, either give nitrate in the diet or nitrite or give a nitric oxide donor, you can see here that the blood vessel is more dilated. These immune cells hone along the endothelium, but they don't stick, they don't migrate through. So you can completely suppress the inflammatory response to a poor diet by taking nitric oxide. And this is the earliest stages of cardiovascular disease. So to go back, take you back probably 15 years, how do we start to develop safe and effective nitric oxide product technology based on real science? So we go back again, these are the numbers, I've already gone over this. But our point was, if we can improve nitric oxide production in animal models, can we protect from injury from heart attack or stroke, or what's called ischemia reperfusion injury? And then if we could, can we trace this phenotype biochemically, then to give us a marker for prediction of risk for cardiovascular disease? Early in 2006, in collaboration with David Leffer's group, started overexpressing the nitric oxide synthase enzyme in cardiac myocytes. And so you can do this transfection. This Western blot here shows that the transfection was successful. You can see that the nitric oxide being produced in the myocardium leads to increased levels of nitrite and nitrate in the myocardium compared to wild type. And these mice are actually protected from heart attack. So if you give them a heart attack, their heart doesn't see any injury. And so we began to look at other tissues. So we saw here that the plasma levels of nitrite and nitrate in these mice were elevated. Very important, because we knew plasma nitrite and nitrate were protective from cardiovascular disease. They improved performance. We started harvesting other tissue of these mice and found that the liver of these mice were also elevated in nitrite and nitrate. And this was a bit surprising, because at the time it was thought that nitric oxide produced in the heart, and by the way, nitric oxide has a half-life of 1 millisecond. So it's produced and it's gone in less than a second. So it wouldn't survive transit to tissues like the liver. But here we find that the liver of these mice that had a cardiac specific overexpression of the eNOS enzyme was changed biochemically. And just to show you here, there wasn't an increased expression of the enzyme in the liver. And so when we occluded the blood flow to the liver for 1 hour of these mice, and then reperfused for 5 hours, and measured these enzymes, liver enzymes, that are reflective of liver injury, these mice did not see any injury from the ischemia reperfusion. So we published this in PNAS in 2008 for the first time, showing and discovering that nitric oxide is a hormone or an endocrine mediator. So nitric oxide produced in the heart is transported through the liver by inorganic nitrite and S-nitrosoglutathione and protects the liver. And it's not the liver, it's the kidney, it's the brain, it's the lung, it's every organ in the body. So this was really a change in paradigm, and told me all we needed to do was improve plasma levels of nitrite, nitrate, and the body takes care of itself. Everything would be protected from then on out. So then the question was, can we replete these tissue stores of nitrite, nitrate, and lower cardiovascular risk through a dietary means? And so we basically designed a diet and gave mice a diet low in nitrite, nitrate, and then we gave it back in the drinking water. And you can see here from this paper we published again in Proceedings of the National Academy of Science in 2007, that mice that are deficient in dietary nitrite, nitrate, we change biochemically their blood and tissue levels. If we give it back in the drinking water, we basically restore it to a normal diet. If we subject these mice to heart attacks, we occlude the blood flow to the coronary artery for 1 hour and then reperfuse for 24 hours, there's a 50% greater injury in the heart. And in fact, not only a 50% greater injury, 50% of these mice didn't survive out to 24 hours. Increase in infarct size, increase in death. If we give the nitrate back in the drinking water, 100% survive the infarct and a significantly less amount of injury to the heart. What about an eNOS knockout mice? So this would be reflective of a patient with endothelial dysfunction. Again, same thing. These mice have lower nitric oxide. We put them on a low nitrite diet. We give it back, and we significantly improve the amount of injury in the heart. There's hardly any infarct in the heart, showing us that if you're completely devoid of nitric oxide and you take nitrite and nitrate through the diet, you can protect from injury from heart attack. So let's put all this together. So how do you restore nitric oxide production? You do this two ways. You stop doing the things that disrupt it. You have to stop using mouthwash. If you're using mouthwash, you must stop. I was on the doctor shows last year showing that if you use mouthwash, you lose the protective effects of exercise. Fluoride toothpaste. Fluoride's a neurotoxin. It's an antiseptic. It kills the bacteria. Get rid of fluoride toothpaste. Stop using antacids and change your diet. And then promote things and do things that have been clinically proven to promote nitric oxide production. Eat a plant-based diet, more green leafy vegetables, moderate physical exercise, infrared light therapy, or take a safe and effective nitric oxide supplementation. That is probably the most important thing you can do. So let me take you through, before we wrap up here in the next 15 minutes, some human data that we were published in collaboration with Texas Children's Hospital and Baylor College of Medicine. There's a group of patients that are born with what's called an inborn error metabolism. So these patients are born without an enzyme called arginine succinate lyase. This is part of the urea cycle. So their number one problem is hyperammonemia because it's a urea cycle disorder. But as these patients, these pediatric patients, are managed through diet and drug therapy, they're still developing liver dysfunction. They develop blood clotting disorders, neurological dysfunction that's independent of recurrent hyperammonemia. They develop resistant hypertension and kidney disease. In fact, many of these kids have to be transplanted at 7 or 8 years of age, or they die of liver failure. So this group of physicians came to me many years ago, and we modeled this in the lab. And we published this in Nature Medicine in 2011, but we discovered a new protein complex where ASL is the tether to eNOS that binds it, that tethers it to the membrane. Without ASL enzyme, this protein complex falls apart, and these patients cannot make nitric oxide. Even though they're given 20 to 30 grams of arginine per day, they can't make nitric oxide. So what this actual study here told us a lot. Number one, the body doesn't use extracellular L-Arginine. It uses arginine that comes from the urea cycle, from citrulline, and then when nitric oxide is produced, you get citrulline as a byproduct. This protein complex converts it to arginine, and this is arginine that comes from citrulline that goes to make nitric oxide. So in this particular patient here that we published in the American Journal of Human Genetics, we made a nitrite lozenge for this particular patient. As you can see, at 5 years of age, he was diagnosed. He had high blood pressure, put on beta blockers, standard antihypertensive therapy. And for 10 years, he had severe hypertension, resistant hypertension. And in February of 2010, he presented to Texas Children's Hospital and put in the pediatric intensive care unit, blood pressure of, I think, 200 over 110. At that time, we knew it was a nitric oxide problem, so the physicians dosed him with isosorbide. 4 days later, he was sent home. Blood pressure pretty well managed, but he developed tolerance to the isosorbide. In February of 2011, he came back to Texas Children's with a blood pressure of, I think, 185 over 115, taking 20 milligrams ISD in 4 times a day. We had the nitrite product that for a clinical trial, and gave him the nitrite, and his blood pressure completely normalized. It was off prescription medication, and he's done very well on this. 5 months after we started the nitric oxide therapy, his heart disease completely resolved. You can see his ejection fraction here. The left ventricular hypertrophy completely resolved in 5 months. Within 2 weeks of starting the therapy, his kidney disease resolved. We increased the number of circulating endothelial progenitor cells and completely cured this genetic disease at a time when no other therapeutic would help this kid. So now we know how to make nitric oxide. That's kind of our claim to fame. Now we can integrate this technology into any technology around the globe in any market segment. So obviously we know that decreased blood flow to the heart causes heart disease, decreased blood flow to the brain due to nitric oxide deficiency causes neurological disease. What about aging? If you're not getting enough blood flow to the skin is an organ, in fact, one of the largest organs. What does it do? It fails. It loses hydration. It loses collagen. Skin begins to sag. You get wrinkles. Well, if we generate nitric oxide, apply it to the skin, you can improve blood flow, improve oxygen delivery, improve collagen deposition, and improve the appearance and texture of the skin. So several years ago, developed a nitric oxide topical serum. These are some before and afters of published clinical trials. You can see here the age spots. This is 30 days using the topical serum twice a day. For 30 days, the age spots disappeared. The inflammation, rosacea, the wrinkles in the neck go away. The varicosity here, you can see this is 30 days. Loss of the broken blood vessels. Wound healing, extremely important here. To heal a wound, you need blood flow, you need to kill the infection. This is 10 days applying the serum to a full thickness ulcer, complete closure. Again, acne, these are the references here. Antimicrobial, improved blood flow, improved immune function, incredible results. And it doesn't matter the skin type, whether it's African American, Asian, Caucasian. Nitric oxide is agnostic to skin color, skin type. Now, let me just end with COVID. Obviously, this is front and center on everybody's mind, but we now understand the etiology of COVID and the coronavirus. The problem is now long COVID, people developing systemic disease long after the active infection is gone. That's all explained by nitric oxide. The increased heart attack, stroke, blood clotting disorders from the spike protein is all due to a loss of nitric oxide. Coronavirus decreases nitric oxide production. The people that are at risk for coronavirus sickness, illness, and death are the ones that are deficient in nitric oxide. So it's the same model as diabetes. If you get COVID, it decreases nitric oxide production. If you decrease nitric oxide production, your ability to get over from COVID is compromised, and your risk of hospitalization, ventilation, and death goes up. And this is explained by the vascular components of coronavirus. So whether it's the spike protein from the active infection, or it's the spike protein from those getting the mRNA so-called vaccine, it's the spike protein that causes the inflammation, causes an increase in blood clotting, that causes the systemic disease from COVID, whether it's active COVID disease or the adverse events reported from the mRNA spike protein. Over 15 years ago, it was shown that nitric oxide donors can actually inhibit the replication of the coronavirus. And this was SARS-CoV-1. It doesn't matter. It's the same. It doesn't matter if it's influenza. Nitric oxide inhibits viral replication. If your body can't make nitric oxide, it can inhibit the virus replication. When you're first exposed, the virus replicates, propagates, and gets you sick. Those of us who make sufficient nitric oxide were exposed to COVID, but we don't get sick from COVID. That addresses every single aspect about this pandemic. The other thing we noticed early on about a year ago was that African Americans were having almost a 6-time rate of deaths as their Caucasian counterparts. We've known for many years that African Americans have health disparities because they can't make nitric oxide. This explains the higher incidence of heart attack, stroke, certain cancers, higher diabetes, higher renal disease in African Americans because they can't make nitric oxide. So to put this in perspective, we know that people who have low vitamin D levels are at increased risk of COVID infection. Those with low zinc, vitamin C, glutathione. How do you do this? If you're low in vitamin D, common sense says, well, supplement vitamin D. Get your levels above 80. If you're low in zinc, glutathione, what do? You supplement it to normalize it. If you're low in nitric oxide, what do? It's common sense to standardize your nitric oxide to prevent increased risk of infection. So we got an IND from another one of my companies called Nitric Oxide Innovations, which is a clinical stage biotech company. We have an IND approved for COVID. We're taking patients that have been onset of symptoms and COVID positive within 72 hours. This is the double-blind, placebo-controlled study, and we're seeing enormous critical benefits in high-risk patients. We're seeing reduced inflammation, blood pressure. This is the fractional oxygen saturation of a single patient with silent hypoxemia, 79. 8 minutes after our nitric oxide drug, the blood oxygen saturation goes to 91. Now we're seeing this. We've got another protocol that we submitted to the FDA trying to prevent in hospitalized patients the need for ventilation. Once you get ventilated, the risk of death goes way up. So we're trying to improve blood oxygen saturation. Going back to one of the very first slides, you need nitric oxide to improve oxygenation. Nitric oxide does that. So what about going back to what is nature? Is this what nature intended? So we go back and ask some fundamental questions. And this was my second son here, Lincoln, when he was first born. My scientific curiosity got the best of me. And obviously when we were discharged, the nurse said, well, you should breastfeed, but if you don't breastfeed, take the breast milk. So I collected a little bit of the breast milk, which was colostrum from my wife at the time. And we compared that to the formula milk that was sent home, given by the nurse. And the amount of nitrite in the formula was barely detectable. But in the breast milk, it was really high, and this was colostrum. Then we got an IRB, and we measured the breast milk of, I think, 30 patients or mothers that had just delivered. And we took colostrum, we took transition milk, and we took mature milk. You can see here the amount of nitrite in the colostrum was very high. As it transitioned, the amount of nitrite got less, and nitrite went up. And this is a figure taken from our paper in 2011, that the ratio of colostrum changes for breast milk. So when babies are born, they're born sterile, so they don't have the nitrate-reducing bacteria. So what does nature do? It delivers nitrite. When gut bacteria begin to colonize, the baby then has the ability to convert nitrate to nitrite, so the breast milk changes and starts to deliver nitrate in the breast milk and very little nitrite. This is different in vaginal delivered babies versus cesarean delivered babies. Necrotizing enterocolitis can completely be reversed by giving nitrite in the baby's milk. We published that, I think, in 2011. So what about from an adaptive standpoint? Are there populations that generate a lot of nitric oxide? We went to Tibet. These people live at 12,000 feet above sea level. These are the Sherpas that take people to the summit of Mount Everest. These people don't get high altitude sickness. They don't get high altitude pulmonary edema. So we measured this, and we published this in 2007, that people that live in Tibet deliver more oxygen per unit time than people that live in the US. Their forearm blood flow is improved. We measured their plasma levels and see that their plasma levels of nitrite and nitrate are 50 to 100 times higher than people living in the US. This told us they have an adaptive response, and they generate more nitric oxide, and that allows them to live in environments with lower oxygen. So this explains altitude training. It's not hematocrit. It's not an improvement in hemoglobin concentration. It's if you take people to Colorado or Mexico City and they adapt and train, they're improving their nitric oxide production, their plasma levels of nitrite and nitrate increase. And then if you go to higher altitude and you're well trained, your body can adapt, you generate more nitric oxide. The problem is if you have endothelial dysfunction, you can't adapt, you can't make more nitric oxide. You develop high altitude sickness, high altitude pulmonary edema. So all of this is dependent upon nitric oxide. Or you can take a nitrate or nitrite and adapt, allow that to adapt for you. So as we wrap up here, let me bring this back that people get sick for 2 reasons and 2 reasons only. Body's missing something that it needs, nitric oxide. It's exposed to something that's toxic or inhibiting nitric oxide production. Infections, root canals, mouthwash, and acids. The result is loss of regulation of blood flow. You get sick, you die. It's really simple. So loss of nitric oxide causes human disease. We see this over time. It's more like a battery, not a light switch. It gradually declines. You start to lose it. So you've got to employ strategies to replete it or to recharge, refill this nitric oxide reservoir. How do you do that? change your diet or use a standardized nitrate product, restore endothelial function, stop smoking, stop using an acid, start exercising. Infrared sauna is a big proponent of that. Use fluoride-free toothpaste and stop using mouthwash. Stop using antiseptic anything. These bacteria are there to help us to prevent viral disease, for example. And I caution people, there's a lot of nitric oxide products on the market, a lot of deceptive marketing, creative marketing with no science. And I published this in 2004 because if you don't know what you're doing, you can do more harm than good. If you give a lot of nitric oxide and you don't dictate and control the metabolic fate, you don't want to nitrizate amines and lead to low molecular weight nitrosamines. These are carcinogenic. You want to be able to control and dictate the metabolic fate. Most companies don't have anybody on staff, it's a biochemist that understands these reactions, that actually mitigate these reactions. So buyer beware, take caution, look for products with bona fide science. This is a simplified version of that, where we can provide nitric oxide-based strategies at every step of the process. But again, we can do this, but a lot of this is dependent upon your own lifestyle and choices. Again, no mouthwash, no fluoride, no antacids. Those have been clinically proven to disrupt nitric oxide production. So let me just conclude here that hopefully I've convinced you nitric oxide controls and regulates blood flow and oxygen delivery to every cell in the body. There's an age-related decline in nitric oxide production, not just age-related, lifestyle-related events that lead to a loss of nitric oxide production. Diet and exercise are not always sufficient. Strategies to restore NO production will have a profound impact on public health and on the future of medicine. And we must use safe and effective nitric oxide product technology in order to optimize our health. We know that we're not getting enough nutrients from our diet. We have to supplement certain things. It's just the world we live in. I'll leave you with a couple of references here. I've got an educational website, drnathansbryan.com. I do a monthly blog to try to provide some timely and practical, what I call common sense issues. This is my latest book, Functional Nitric Oxide Nutrition. It's a lay read. For those that want a more technical read, this is an edited book that I edited with Joe Lascalzo, who's chair of medicine at Harvard Medical School and chief of cardiology at the Brigham. And really, this hardback book here provides everything we've known and learned over the past 30 years into a single collection here. And we'll have a chance to answer questions, but if somebody doesn't get their question answered, please feel free to email me at drnathanbryan@gmail.com. And I'm sure we're going to have a lot of questions related to Berkeley Life. I've been in the nitric oxide field for over 20 years. There are a number of companies that I've partnered with that have licensed my technology. But I'm very excited to partner with Berkeley Life for a number of reasons. It's healthcare practitioner channel focused. So me being in academia for more than 20 years, we want to get the message out, inform those on the front lines of the importance of nitric oxide, to give healthcare practitioners the tools that they need to make their patients better. So the importance of this is, number one, it's focused, Berkeley Life is focused singly on nitric oxide science and product development. So your patients don't have to worry about going to Amazon or going to other company websites and competing with your patients for that product. And we share the same mission to change the landscape of healthcare by educating healthcare practitioners. And again, strong commitment to safe, efficacious products backed by real science. So you never have to question if a Berkeley Life product is going to deliver on that brand promise of nitric oxide in the healthcare practitioner space. So with that, again, I thank you for your time. I know everybody's busy. There's nothing more important than the time we give, and I'm certainly appreciative and thankful for the time that you've devoted in listening for the past hour. So with that, I think we'll wrap this up and we'll open it up to a few questions. But thank you very much for your time and attention.